I was looking those pictures, everyone was saying, why is it so that everyone who has come with this tumors and all, at that stage, why not early?
Yeah, almost 80% of our patients come in stage 3 or stage 4.
Why do they ignore it?
The reason is, first of all, denial.
It's not okay.
ये मुझे कैसे हो सकता, मुझे नहीं हो सकता. And by the time they try to accept something is wrong, the tendency in village side, one thing, access is less, awareness is less. For that, they tend to go into alternative methods like traditional healers, alternative medicine.
It's like balm and heat.
And then they go to practitioners' clinics. Again, many times they waste a lot of precious time giving antibiotics, analgesics. By the time they realize it's malignancy, it's quite an advanced stage. And after realizing, again the patient will think, half of them, they lose their desire to fight. They give it up, thinking nothing can be done. And there is a small subset where the family shuns them. It would have started fungating and all that, and there will be smell, and they think, poverty is rampant. They think instead of investing on an elderly person who is losing it out, who is going to lose his or her life, let us invest on children or something. So that tendency is there in rural India. It's unfair, it is sad, but it is there.
Like talking about the patient, is there any unique case that you want to share with us?
We have had many like that, cases which were considered inoperable. Like I just showed my 52 case series, advanced oral cancers extending to infratemporal fossa, and it was published in 2018. Similarly, later on, rather while that study was going on, we took up another study where we randomized 45 patients in each group. One group we gave only upfront surgery followed by adjuvant treatment. The other group we gave neoadjuvant chemotherapy, 2 cycles of paclitaxel and carboplatin, followed by surgery and adjuvant. And we compared. In fact, that we have sent for publication, it's under review. So this was considered formidable area. During my PG course, if I had said I will operate such a cancer with trismus, I would have been immediately failed. Now we are operating it right, left and center. Such cancers are, I showed you a few thyroid mountains, I should say. One particular lady from Philippines, she was working in Middle East. She had already undergone hemithyroidectomy in Philippines 3 years earlier, developed recurrence, and it was huge. With that, she was uncontrolled hypertensive, case of renal failure, and that was one of rare cancer, because when we say thyroid cancer, they're either euthyroid or hypothyroid. Only 1 to 4% of thyroid cancers are hyper, and unfortunately she happened to be hyperthyroid also. So no one was prepared to touch her in Middle East. She came to Bangalore, a lot of people either refused her or the cost was sky high. Then she landed with us and we operated her. She's doing well.
In your talk, you mentioned that other than the cancer cell features, the intercellular crosstalk in the tumor microenvironment is also important. So when it comes to, let's say, response to therapy or surgery, do you think this crosstalk might be determining the relapse or stuff like that?
Yeah, it matters a lot, because this is an area open for exploration, I should say. Because many times we see they respond to first cycle and second cycle, and by the time they even become fit for surgery, usually we operate about 12-15 days after the completion of chemotherapy cycles, the tumor starts growing. And even where it responds, we have something called diluted margins in post neoadjuvant chemotherapy. That is macroscopic, the tissue will look fine, and of course there may be some edematous tissue, but when you resect it, the margin may be positive. So when we go in for surgery, though we are aiming at downstaging the tumor, it seldom happens. It's just the access which is better. So the resectability becomes little more easierly, a little better working field. That's all I should say. The complete response after chemotherapy is less than 5% in head and neck squamous carcinoma. So we are looking at partial response. And in the study which I said, the partial responders among very advanced oral cancers, when they are operable, better to knock it off first. When they are borderline inoperable or your OT list is long and you are scared by the time they come to table, they are inoperable. In such cases, to apply breaks, you can go in for neoadjuvant chemotherapy. And such cases in our small study, the partial responders have fared better than upfront surgery in these very advanced oral cancers, basically T4Bs.
So let's go back and what and how come you decided that you want to become a oral surgeon?
Yeah, I'm head and neck surgeon. Oral surgeon is a term after dental and maxillofacial. They operate head and neck, but majority of them don't operate larynx and thyroid. So I'm head and neck surgeon. As I said, during my MBBS days, I was fascinated by general surgery. Soon after MBBS, started working in cardiology. My interest deviated to general medicine. Entrance got a PG seat in ENT. So I was fond of surgical field. And as I told, somehow ear surgery didn't give me that sort of a kick or euphoria, I should say, because the field was small. For me, by nature, the field should keep moving. The small gadgets make me paranoid, let me be very honest. So I was better off with head and neck surgery. I had to do ear surgery and did well, but I wanted to subspecialize in plastic surgery, landed in oncosurgery, and no regrets. Even my reconstructions I do by myself. And I've had set of very good teachers, be it Dr. Gopinath, Dr. Sultan Pradhan, Dr. Anil Dikros, etc. In my surgical training. And when I came back to Kolar, seeing the cancer load there, I thought this is where I want to concentrate. This is my passion.
So these advanced gadgets, the surgical gadgets, these methods, are they available in India and are they
very much? Okay. Very much available. Whatever I showed you, they are available in India. Yes, in Kolar we don't have the sort of nerve monitoring that I showed you, and we don't have indocyanine green fluorescence as I showed you. Once it came for parathyroid use, the cost shot up. That's one unfortunate thing in our country. And similarly, we don't have CUSA for neurosurgeries, and we don't have navigation system. But then we have been doing the mucor outbreak. We operated 59 cases, out of that 53 patients, and the rest surgery for recurrences. And it was all skull-based surgery, advanced endoscopic surgery. We didn't have navigation system. It didn't stop us. The results were good. If we have something, it makes life easier. But those who discovered these surgeries, they had nothing when they operated. Like if I say I drove from Bangalore to Kolar, I have not achieved much. If I find a shortcut, or if I calculate this point to this point traffic, this is the speed, that point to that point, this speed, and it reduces time by so much, then I have contributed. So whoever has made these discoveries or inventions has started with nothing and contributed. I see it that way.
So there's one question more, which is the role that you best enjoy? Not as a clinician, as a medical accommodation, and researcher or inventor, and why?
Inventor, I have not stepped into that territory still. Yes, as a clinical professional, that's one thing I would like to convey. The laboratory to hospital distance should reduce. What NMC, that is the governing body for doctors in this country, insists is scientific surgeons. We don't want skilled craftsmen who can do fantastic procedure without knowing the full implications. Nor do they want people who will only do research without any benefit for the patient. They want scientific surgeons. And that can't happen unless we are lifelong learners and collaborate with other disciplines, other specialities, other subspecialities, etc. So we can't be compartmentalized these days, I feel. We need to be jacks of all and maybe jacks of many things and maybe master of one.
So I'm a new scientist and I'm also working in cancer biology area, and this point that you cited, that the gap between the clinicians and that has to be bridged. We often feel that as a clinician, what would you suggest? I mean, what proactive measures we should be taking?
First of all, right from the inception into medicine, if they are exposed to a little bit of research and what pure science they study in pre-university courses. If part of that which is associated to their course is continued during their earlier years, for example, a cell cycle or basics of genetics, if it continues, they will have that continuity. So when they come into the real life situation, growing in that field is easier. Otherwise, after a gap of 4 or 5 years, they would have forgotten, except Gregor Mendel's name, they won't remember anything in genetics, let alone epigenetics or allied sciences. So I think that continuity is a must. And now it's all the more important. If you take the standard textbook for physicians, Harrison's, the first few chapters are quite focused on genetics. And unless we are aware of that, you cannot straight away jump after your post-graduation. So that is one area. And another is collaborations. Unless we have collaborations, for example, a molecular scientist attending tumor board and a clinician on and off coming to the lab, seeing what's going on, how to do it, what are the inferences and implications. Unless that is there, we are working in particular pockets.
Right. We should be like exploring.
We should venture out a little bit to understand medicine, and from that side, we should be.
When I started collaborating with molecular labs, be it within our institution, be it with Tapas sir, be it with IASC, many of my friends thought I am crazy. But now they have started seeing the significance. And they also want to do it.
Talking about Professor Kunnu's research in epigenetics, considering the kind of oral cancer is there in Western world being so different from what we find in India, I believe their epigenetics would be different. So do you think in future this epigenetic variation could be part of, could we exploit some of the epigenetic modulators for treatment?
Actually that is the direction and way to go. Because if you take the statistics, head and neck cancers, not just oral, head and neck cancers constitute about 3% of all cancers in Western countries. Whereas our country, it's 26 to 35%, depending on various regions. In Kolar, it's around 30-31%. So each area has its own epigenetic signatures. And the carcinogen, the carcinogenesis initiating substance itself is different. It may be gutka in one place. If you go to Gujarat, Maharashtra, even northern Karnataka, it's gutka, arecanut, etc. If you go to northeastern states, it's pure arecanut, and the way it is taken is also different in various pockets. So in Gujarat, Maharashtra and all, carcinoma tongue is quite common. whereas in Kolar, majority are buccal mucosa and lower alveolus. In fact, these people have a habit of keeping a tobacco quid in their cheek, sometimes overnight.
Yes.
So they come in late stage. You don't know which side the cancer initiated, whether it's buccal mucosa or lower alveolus, because both will be involved by the time they come. And dat sulcus, though it's not a oncological site in Western books, and this cancer originates in gingival-buccal sulcus, and it has been nicknamed Indian oral cancer. Yeah, so there are geographical variations. Even the response to treatment, everything is different. Like Tapassar's lab in JNC, they are working on mutations on P53 in these gingival-buccal cancers among ladies only, and it has shown promising results.
So is it possible to have these oral cancers, throat cancer? The reason, could it be other than having these tobacco?
Yeah, genetic mutations can happen. In oropharynx in the Western world, HPV-induced cancers are relatively common. But in India, it's still less. And whatever is there is more in urban centers. Rural India, it's very less. Or if it's there, we don't know. It may be overshadowed by the more aggressive tobacco-induced cancer.
So I've already asked this. What are the major challenges in preventing oral malignancies in our country?
The first and foremost,
it's preventing.
First and foremost, awareness. People have to understand that it's not only their health, their family's well-being, the society at large, their children, grandchildren may be seeing them take. And in our country, each one thinks he's a he-man. Mujhe nahi ho sakta. So they say once a sinner, always a sinner. Same thing with addictions. Once you're addicted, it's very difficult to come out. So the answer should be no for the first time. And it depends on their will, awareness, and there's a lot to do for us in preventive oncology. The screening studies itself, except Shankar Narayan's study, which was published in Lancet almost 10 years back, no big screening study has really happened in this country. We need to focus on these things.
People say that tobacco is injurious to health, but still...
See, once they are addicted, it's very difficult to come out. Like I have seen post-laryngectomy patients hiding in the bathroom, and their airways separated permanently from their foot passage. I have seen them smoking through tracheostoma.
That much addiction.
That much craving they have for
So do you
tobacco.
think that some kind of psychiatric counseling should also be part
Yeah,
of the treatment?
yeah.
Because the
See,
success...
that's another myth in our country. The moment they hear psychiatrist, they're labeled as mental disorder. That has to go. Psychiatric counseling addresses stress. Psychiatric counseling addresses addictions, family behavior, everything. Somehow the general public doesn't see it. The moment someone goes to a psychiatrist, ye to pagal hai.
There's a taboo, there's a taboo.
Yeah. So we need to come out of all these things. And yes, you're right. While counseling a patient for surgery, I think a psychiatrist also plays a major role.
Yes.
Last question. So, any message from you to the CDRI community?
Having come here was an honor to me. I was fortunate, and it was my privilege that I was given an opportunity to visit this esteemed institute. Only thing, like as I said, we need to have collaborative studies, work on modules through which we can either block the carcinogenesis or bring in affordable, effective care for these cancers, or at least pre-malignant conditions. If we can do that, I think we have would have given a lot to the underprivileged people in this country, and that's what I'm looking at. And an esteemed institution like CDRI is the one which can lead research and outcomes in this direction, and I'm humbly looking at CDRI for delivering in this.
It was also a great pleasure to hear from you that extensive presentation.
It was a pleasure, and I'm indebted to Professor Kundu for having given me this opportunity. And of course, since more than 12 years, he's been teacher, mentor, well-wisher, everything for me. And in spite of all that, he's so modest. That's his greatness.
It was a great opportunity for
Thank
us
you,
also.
madam. It was nice meeting you. I definitely look forward to working with you so that we can do something for our underprivileged patients. I think we need to join forces and deliver something to them which will help them.
Thank you.
Thank you. Thank you.